Հանրաճանաչ վիրաբույժ բժիշկ Ջան Վարդանյանը մասնագիտացել է դեմքի գեղագիտական վիրաբուժության մարզում։ Նրա շքեղ գրասենյակը արդիական սարքերով ծառայում է իր հաճախորդներին, նրանց դեմքերին տալով բնական արդյունքներ։ Վարկավորված բժիշկ Վարդանյանը ուսուցանում է UCLA-ում եւ USC-ում։ Նրա մասնագիտությունը ընդգրկում է քթի եւ կոպերի վիրաբուժություն, դեմքի վերաթարմացում, ճառագայթային գործողություններ եւ վարսատնկում։ Զանգահարեք մեզ վիրաբուժական կամ այլ սպասարկությունների ցանքի համար։
Good evening, ladies and gentlemen, and welcome to Stay Your Health TV program. Today we have with us Dr. James Tabibian. Dr. Tabibian, welcome to our program.
Thank you.
Dr. Tabibian is a gastroenterologist and an advanced endoscopist and is currently the medical director at Adventist Health Glendale of the interventional GI program there. Dr. Tabibian has extensive training from various medical institutions, including UCLA, Johns Hopkins, the Mayo Clinic, and UPenn. And he has extensive expertise in advanced procedures such as EMR, ERCP, EUS, all of these which Dr. Tabibian, I'd like you to explain later on in the program. Dr. Tabibian is also a published author as well as a trusted reviewer for the California Medical Board. Again, Dr. Tabibian, welcome to our program. I want to just dive right into it. Now, you are a gastroenterologist and you have additional specialization within the field of gastroenterology by being an interventional gastroenterologist. I'd like you to just take a few moments and explain to our viewers, first, what is a gastroenterologist? What are things that gastroenterologists do on a day-to-day basis? What are some of the medical conditions that a patient would come and see you? And some of the common procedures, especially the ones that we mentioned in the introduction.
Sure. Thank you again for having me. So a gastroenterologist is essentially a physician who specializes in digestive diseases or digestive disorders. So conditions of the GI system, as we call it, which typically includes the esophagus, the stomach, the small intestine, the large intestine, and to some degree also the liver and the pancreas and gallbladder as well. So patients commonly will see a gastroenterologist for things such as chronic heartburn or GERD, as it's called, gastroesophageal reflux disease, for changes in their bowel habits such as constipation, for abdominal pain, for anemia that maybe their primary doctor or their hematologist thinks might be related to blood loss or inadequate absorption of nutrients from the gastrointestinal system. And the bread and butter of gastroenterology, of general gastroenterology at least, is usually upper endoscopy, which entails a camera scope through the mouth, and colonoscopy, which is a camera scope through the bottom, through the rectum, and maybe analogous to cardiology, where you might have a general cardiologist who takes care of things such as maybe arrhythmias and blood pressure, maybe cholesterol. But that's a general gastroenterologist tends to, I would say, some of the first line issues in gastrointestinal disease management, but then just like cardiologists have interventional cardiologists, heart failure specialists, electrophysiology specialists, structural heart specialists. Gastroenterology is also similarly subspecialized or subspecialized into different niches, so to speak.
Great. And in terms of, you said that endoscopies are sort of bread and butter, so to speak, of a gastroenterologist. Let's talk about the various types. Now, you did mention there's an upper endoscopy, which typically is a camera that goes through the mouth and looking at the upper digestive system, and a lower endoscopy, which we commonly know as a colonoscopy or variations of it. If we could start with that, I mean, Let's start with the upper endoscopy. What does that entail? What prompts a gastroenterologist to recommend an endoscopy to be done, and how is it done? Is it under sedation? What should a patient expect?
A great question, a big question as well. So, at a very high level, a upper endoscopy, which we also sometimes refer to as an EGD, which stands for esophago-gastroduodenoscopy, referring to the three main areas that we're able to see or we're able to scope during an upper endoscopy. This procedure is typically done with some form of sedation or anesthesia. There are different options that we try to fit or match to the individual patient. Some people want deeper sedation, some people want lighter sedation, some people want no sedation. They just want their throat to be numbed, and that's doable as well. And it's a very short procedure, generally speaking, unless we come across something that requires more time or work, such as maybe a large polyp in the stomach or in the small intestine that needs to be removed. But generally speaking, it's probably a 5-minute procedure. The entire package of having that done does take longer because you would need to come get checked in, have an IV placed, vital signs measured, the procedure done, and then recovered. So depending on where someone has it done, it could take more like an hour or two or three, sometimes even longer, again, depending on some of these variables. But the upper component of upper endoscopy is just the gateway to many different things. We can access the bile ducts through the mouth. We can access the pancreas through the mouth. So what exactly we do during an upper endoscopy can vary quite a bit. And just endoscopy in general is kind of our catch-all term or the umbrella term. So like you were mentioning, there's upper endoscopy, there's lower endoscopy, which we oftentimes refer to as colonoscopy. But there's also a baby colonoscopy that we call sigmoidoscopy. It's not as detailed or as long of an exam. Yeah, there's many combinations, permutations. Sometimes we do upper and lower on the same day. It really depends on what the patient has going on, what the concerns might be, and what their preference is. Some patients want to do both at the same time. Some would prefer to keep them separate. We kind of have seen many different versions of this picture.
Now, let me ask you about preparing for these procedures. What would a patient expect in terms of prep? I know that to some degree, especially if there's going to be a colonoscopy, one would need to prepare their bowels or clean out or whatever have you. If we can go over the various upper and or lower, and what are the preparatory steps for these procedures?
Sure. So generally speaking, for any endoscopic procedure, you need to be fasting for 8 hours. So no solid foods for 8 hours or solid substances. You can have clear liquids up until, in small volumes at least, up until 2 hours prior. Sometimes they'll say 4 hours prior, but they being the anesthesiologist or the gastroenterologist. So I think 4 hours is probably a safer bet. And again, small amounts of clear liquid, not a huge amount. And we do that because during this procedure, either because a scope is entering the body or because of sedation medicines or other factors, we want the stomach to be empty so that there isn't a risk of regurgitating or vomiting, and which it can lead to a separate set of issues, something that we refer to as aspiration. So that's one aspect of it. And as you mentioned, if someone is undergoing a colonoscopy, the colon needs to be cleansed or prepared. So we use the term bowel prep referring to preparation. And really, there's no good way around that other than drinking a large volume of liquid to flush out the colon. What liquid you drink? There's actually a lot of options now. There's over-the-counter approaches. There's prescription. There's tablet-based. So it's not there isn't a one size fits all. We try to work with our patients to see what they prefer, what their insurance covers, what's easier for them, what's more palatable for them. But that usually needs to be done the day prior or the evening prior, so that again, we can make sure that the patient has been nothing by mouth, or NPO is what we call it, for at least 2, if not 4 hours, even with just clear liquids, which the bowel preparation is a clear liquid.
I see. Now, what are, like, from the standpoint of common, things to keep an eye out on, like potential complications? What are, like, some things to look out for? How do you counsel the patients?
Sure. I think it's helpful to think about potential complications or risks or adverse events in 2 broad categories. One is related to the sedation or the anesthesia, and the second is related to the procedure. So with the anesthesia or the sedation, some people can have reactions to the medication. Some people might feel groggy for a longer period of time. Those are kind of the main issues there. Usually, if there's an anesthesiologist involved, they'll go through that separately, because that's really their area of expertise. As far as procedure-related complications, it really depends on what the procedure is, why it's being done, and what the patient's medical or surgical history is. So, for instance, upper endoscopy and colonoscopy, generally speaking, very, very safe procedures, very, very low risk or incidence of a serious adverse event. But they can happen, and so it's good to have a history ahead of time to know what to potentially anticipate. With colonoscopy, for instance, probably the most dreaded complication that at least I could think of is either bleeding, causing bleeding during the procedure. For instance, a polyp is removed and it bleeds a lot. And the second is perforation, meaning we try to remove something perhaps, and the removal process, it goes too deep and there can be a hole in the colon. But sometimes you can get a hole in the colon or a perforation just from maybe pushing too much, trying to advance the scope. And that's very, very unusual, I think, in well-trained individuals. But the risk of it goes up in folks who, let's say, have had numerous prior abdominal or pelvic surgeries. So I usually ask every patient, have you ever had any prior abdominal or pelvic surgeries? And a lot of them will say, no. And then I say, well, how about appendix? Oh, yeah, I've had that. Or how about a hysterectomy? Oh, sure, yeah, I had that as well. And so these things start coming to our mind, and they do impact what we encounter during colonoscopy. So if I know that someone's had a hysterectomy and I get to an area where I feel like the colon feels very kind of just, it doesn't want to move, it's not flexible, it feels fixed. Having that surgical history in the back of my mind is useful, because I might say, you know what, we can't push this scope. We need to come out and use a pediatric scope or an upper scope that's even smaller than a pediatric colonoscope. So we do everything we can, or we should be doing everything we can to mitigate or minimize those risks, whether it's anesthesia related or it's procedure related.
Of course. Now, you've already mentioned some of the things that you can run into, but let's say you see something suspicious. Now, we know that, and we have previously spoken on this program when you were a guest, that one of the indications, well, everybody really 50 years and older should have a colonoscopy, right? That's a screening colonoscopy. Some of those recommendations change from time to time. But let's say you're in for a routine screening colonoscopy, and what are potential things that you can run into that you would consider as suspicious?
So during a colonoscopy, let me also take this opportunity. Now in the U.S., for just only a few years now, our screening age is 45. So it's now no longer 50, it's 45. And it doesn't have to be a colonoscopy. We have other options as well. Colonoscopy is regarded as the gold standard. It's the only really technique to visualize the entire colon and to remove a polyp, which is a precancerous growth oftentimes, before it turns into cancer. So no other modality or testing option offers that those features. But so I tell patients, have something done, whether it's a colonoscopy, whether it's a stool test, whether it's something else, just do something. Something's better than nothing. But what we can find during a colonoscopy that's suspicious, for instance, is a very large polyp. A polyp that really, it looks ugly. It doesn't look like a friendly polyp. There are polyps that are completely benign. They have no cancerous potential. And then on the other hand, we have polyps that are becoming or have already become cancer. So that would be probably one of the more worrisome things I could or most worrisome things I might come across. And and how we would manage that would depend probably on where it's located, how big it is, and things of that sort.
Now, let me ask you this. Now, you see a polyp. The approach would be, or some sort of a worrisome, lesion, the approach would be to remove it if possible, or to biopsy it, correct?
Yeah, so if we think it's safely removable, we'll oftentimes plan to remove it. If we think, if we have hesitation about removing it, for instance, because it's very, very large, or we're not sure what it is, if it's even something that should be removed endoscopically, or if the patient's on a blood thinner, let's say they couldn't stop their blood thinner with enough, time in advance, then we might just biopsy. Sometimes we'll also place a tattoo because some things can be either difficult to find a second time around, or we're marking it actually for a surgeon to say, this is where we saw it. We're placing this tattoo in the wall of the colon or wherever we are in the digestive tract to serve as a sign that this is where it's, focus here, and then cut or resect or remove with these, margins in mind or borders in mind.
Now, if you are doing a biopsy or resecting a polyp, is that something that during the procedure the patient feels at all?
I would say 99 times out of 100, no. And actually, biopsies, interestingly, when we biopsy the gastrointestinal tract, the esophagus, the stomach, the colon, there's no sensation. So I could take, and I have taken in some cases, let's say 30 biopsies. You do not feel it whatsoever. What you might feel is if it's a very large, let's say, a lesion that was removed and we have to use electrocautery, or let's say electrical energy to cut through the tissue. Sometimes that can irritate the nerves in the wall of the digestive tract, whether, again, doesn't matter really which organ we're in. So that it's almost like a burn, if you will. So that can cause pain. Usually it doesn't, but for things that are very large or very deep, you might have that. It tends to be self-limited. It can go away, within a day or two, or with just some Tylenol. But typically what we do on the inside is not felt during or even after the procedure.
Now, let me ask you, you mentioned earlier that the new recommendation of screening for like colon cancer is now at the age of 45. So colonoscopy being the gold standard. So that's one of the options that all 45-year-olds could opt to do. There are some other options as well. However, what circumstances, if any, do necessitate or indicate an individual younger than 45 that they may need a colonoscopy?
Mm-hmm, mm-hmm. Well, that's a great question. I think of this in probably two buckets, if you will. One is the patient needs it earlier because they are at increased risk of having colon cancer or having what we call advanced adenomas, or polyps that are on their way to becoming cancer. And who are those folks? Well, anyone with a first-degree relative of colon cancer diagnosed before the age of 60 would count. Anyone with two family members with colon cancer, regardless of age and regardless of how closely related they are, but it would need to be a blood relative. There are also some cancer syndromes, which are not very common, But I think as we learn about them and have more means to test for them, they're becoming more apparent. Some of these aren't exclusive to the GI tract or to the colon. There are cancer syndromes that predispose to ovarian cancer, to uterine cancer, to breast cancer, and they're also related to some GI cancers as well. So I think knowing that family history is important. So if you have multiple family members, even if there's nothing diagnosed as far as a syndrome, but you have multiple family members with solid organ malignancies, breast, pancreas, kidney, stomach, colon, uterus, you should probably see someone for that. And maybe you need a colonoscopy prior to the age of 45. Or maybe even an upper endoscopy. It depends on what the history is. So I think that's one bucket is increased risk of or higher than average population risk of cancer that might trigger an earlier endoscopic evaluation. The other is symptom-based. So regardless of what your family history is, regardless of what your risk is for having, let's say, colon cancer, if you have certain symptoms, you might need a colonoscopy or an upper endoscopy or both, because there's other things aside from cancer that are important to find and diagnose and treat. So for instance, if someone has severe iron deficiency anemia, let's say a 30-year-old male, why would a 30-year-old male be severely anemic? There aren't a lot of good reasons, at least said another way, there should be some kind of explanation for it. And many times it originates in the gastrointestinal tract. But through that kind of testing, we might find that the patient has celiac disease, which causes anemia. They might have inflammatory bowel disease, like Crohn's disease or ulcerative colitis, which is actually common in Armenians. And it may or may not cause bloody diarrhea. That's a phenotype or a sign, but some patients just have some abdominal cramping or uneasiness or altered bowel habits and anemia. So, so there might be signs or symptoms or both that should alert us as providers, either a PCP or a gynecologist, a gastroenterologist, that, hey, this person might need further evaluation, including but not limited to endoscopy or colonoscopy.
That's very good. And I know that the field of genetic oncology, so that is really evolving, and the recommendations for testing family members of these various conditions that are predispose somebody or puts them at higher risk of cancer is evolving, and we should always be plugged into that. But I'd like to take a few minutes, Dr. Tabibian, and ask you if we could just discuss what are some of the alternatives for screening for colon cancer outside of colonoscopy. I know we touched on it briefly, but if we can talk about all of the options that one may have as screening modalities for colon cancer in a low-risk population, or if
Sure.
they're also at high risk.
Yeah, so aside from colonoscopy, there are several options. I think some are considered higher tier. In other words, there's a stronger case can be made to justify them. They're more trustworthy. Some are higher tier than others. I typically limit options that I would recommend to patients to, if not colonoscopy, then stool-based testing. There are currently two main stool-based testing options that are considered high tier, either tier 1 or tier 2, if we look at current US-based multi-societal guidelines. And those are FIT, which stands for fecal immunochemical test. And the second is Cologuard, which is also a stool-based test, but instead of only looking for evidence of blood in the stool or microscopic blood in the stool, it also looks for certain genomic changes that could indicate precancerous growths. If I had to choose between these two, I would unequivocally opt for Cologuard. It's a more sensitive test. It's a better test. It's more comprehensive, and I do recommend it to a lot of patients. If a patient says, "Look, I'm a pescatarian. I eat a Mediterranean diet. I have zero family history that I know of colon cancer. I have no symptoms. I have a bowel movement daily. I'm in great shape. I don't smoke. I don't drink." I would say, okay, well, I mean, there's no reason why we have to do a colonoscopy. If that's what you want because it gives you peace of mind, we can do it as well. But that's a person who I would say, wow, this person is really, really, as far as we can tell, low risk for having a advanced polyps in the colon. So I would offer Cologuard. Cologuard, if it's mailed to your house, if it's negative, you're good to go for 3 years. In 3 years, you need another checkup, whether it's Cologuard again, whether it's colonoscopy at that juncture. It's flexible. And anyone who's not average risk or not low risk, so because of a family history or because of a cancer syndrome in the family, these options are out. It's colonoscopy. So I think that's important to know as well. And then the question is it colonoscopy at age 45 or even earlier? Usually it's even earlier, like 40, or maybe even earlier than that, depending on some of the details of the family history. But I don't see any issue with stool-based testing. Some of my peers might think that it's just not sensitive enough, and so that can become a scientific or academic or philosophical conversation. But I think those are the two main options: stool-based or versus colonoscopy. There is now a blood-based test that just became FDA approved within the last year. I just don't think it's ready for prime time. It's an option. If someone said, I cannot collect my stool, I just won't do it. There's no way I'll do a colonoscopy unless I know if there's something in there. Then I would say, well, I guess we could do the blood-based test, but just know it's not very sensitive.
Of course, yeah. And this is very important for us to periodically to update. We're in 2025 now, and that's the recommendation. And you already, I think, began to touch on this. We have about a minute left, Dr. Tabibian, and I always like to touch on prevention. What are some of the recommendations you can give to our viewers in regards to lifestyle or any other recommendations when it comes to trying to prevent colon cancer even occurring?
Yeah, so what's been shown in very large, even population-based studies in different countries, including the US, is the following. And some of these are more important perhaps than others, but avoid saturated fats, avoid smoking, eat plenty of vegetables, grain fiber as well. Fruit is helpful also, but I think vegetables and grains seem to have a better impact. Moderate alcohol consumption, and processed food consumption as well. And really beyond that, there isn't a whole lot that I could think of, but just make sure that when time comes, whether it's 45 or sooner, be screened in one way or by one technique or another. Don't wait for symptoms to arise. Stay ahead of the game.
Yeah, these are very important recommendations, Dr. Tabibian. Thank you very much for being with us and for your time and for sharing your expertise. Unfortunately, it's time to close this program. We'll invite you again periodically to update us on what's the latest news within your field. And ladies and gentlemen, thank you for your time. Thank you for being with us. We'll be back with you in 2 weeks. Until then, please stay healthy. Good night.
Thank you.